That sounds good. All right. Good morning, everyone. Thank you for joining us today for the STAB work group on all data and fall injury prevention topics. So this is a subset of our state trauma advisory board, and really wanted to thank everyone who's given us great feedback at the last two meetings in regards to questions about our fall data, fall injury prevention, fall education, and what we can do to improve the outcomes for these patients across the state of Arizona. So we're going to just do a quick round of welcome. I'm Gail Bradley, the medical director for the Bureau of EMS and Trauma System at ADHS.
Hi, good morning. I'm Rachel Garcia, Bureau Chief at the Bureau of EMS and Trauma System. Good to see you guys today.
I'm Monica Strogan. I'm the EMS coordinator for Peoria Fire.
Jill Barton-Brown, EMS Captain, Peoria Fire.
Sarah Latham, Injury Prevention and EMS Coordinator, Valley Wise Health.
Kimberly Bame. I'm the Trauma Center Compliance Officer for the state of Arizona.
Horace Taylor, Assistant Chief Ford Fire, President of Western Arizona Council EMS.
Ryan Southworth, Director for Gila River.
Jones, Ortho Stab Representative, and then Director of Ortho Trauma for DEL.
Crystal Slauson, Injury Prevention Trauma Outreach with Honor Health Osborne.
Tammy Eidler, Trauma Program Manager for Honor Health Deer Valley.
Dave Hansen, DHS, Naloxone lead behind program guy.
Shelley Bissell, the Bureau of EMS.
And I'm going to just do a quick audio check. Is the audio any better for those online?
Very quiet on my end.
Might have to move you closer to a tile. Unless you want me to request a microphone.
They take a microphone. Let me see if I.
What's the closest tile?
The closest tile is going to be me sitting in the center of the circle, which I could do. I've done other things. You can sit down. See. Do you want us to move over? Is the audio any better if I am right here?
Just yell into the ceiling.
Said yes. Get my coffee.
Well, drinks.
Shirley, do you want to actually see if we can maybe get a microphone in the room? Because I think with participation in the room, so yes, audio between anyone online should be loud and clear. But if you guys cannot hear us well in the room, we're going to see if we can get a microphone. That way, obviously, this meeting is about participation, so we want to make sure that you guys can hear everyone that's in the room as well. So the first thing we wanted to do was to open the slide deck, if we can do that. Just a second here while we're working on the audio issue. Sorry, the slide deck, please.
Yes, ma'am.
Thank you. All right, so just wanted to go through kind of our goals for today. So we've covered obviously the welcome introductions. We are going to go over our current falls dashboard, look at some of our hip fracture data that we have there currently, look at some definitions for severe falls, talk about brain and spine injuries, functional status at the time of discharge, anticoagulation use, questions that came up regarding lift assist falls, pediatric fall data, and then just in general education and fall prevention. Next slide, please. What I'd like to do is to go ahead and click on our dashboard here and spend some time looking at what we have currently in the falls dashboard. And this is something I don't know. Vatzel, I see you're on the line. If you want to maybe talk about some of the data that's on here to give people an idea, and I don't know if we can make that any bigger for those online, Shelley, in the room.
Sure. Good morning, everyone. So falls dashboard, what we have done over here is that we have divided into two tabs. The first tab, which talks about fall related discharges, which comes from hospital discharge database. And that means in order to, as we know that, we do not enter all the falls in the trauma registry. And because we wanted to understand the burden of fall in the state, I decided basically it would be good that we have a trauma registry and hospital discharge registry, both data presented in the dashboard in order to understand the actual burden. So the first tab talks about hospital discharge database, and then the second tab talks about our trauma registry, which is kind of for easy understanding. It says severe falls, but severe falls does not mean that it has anything to do with the severity score, which we collect in the trauma registry. It still has all the falls collected in the trauma registry, nothing to do with the severity. Severe falls is only because it comes from trauma registry. It is easy for any layman who is looking at the tab can understand that, okay, you know, if it is going to a trauma center, it is little different than any other hospital the patients are going. So if we look at the falls data related discharges, we have several filters available to understand the demographic picture of the falls. We have level of fall, which shows falls from height and ground level falls. Then we have hip injury also available. It's all falls, or I just want to look at it if the falls with a hip injury, what is that? Then we can select that. And we have population filter available, which talks about either the pediatric or geriatric groups or all age groups. And obviously we have year, and I think I have 5 years of data available in the filter to choose from. And the first graph actually shows us over the last 5 years, the trend of number of falls, and it has been from 195. There was a drop in 2020, but again then we are back to almost 200,000 falls in the state of Arizona, which is a really significant burden, shown by the number we can see over there. And then we have to identify the populations. We have race, age, gender, the county, the thing, and then the fatality in deaths and other outcomes in falls. And what we see over here is that even though the fatality, it says 0.7%, 11% discharged to rehab or long-term or SNF, and 2.83 required transfer to acute higher level of care. If I look at the county-wise, some of our rural counties are more compared to the urban counties, the problem of falls is. And as we see the age group wise, we see as the age increases, the number of falls are increasing. And more so in females compared to males as the age increases. Then we can go to severe falls. Now in the severe falls, again, it is all the falls coming from the trauma registry. And as we see over the years, that number has increased from 23,000 to 34,000 now in 2022. We have provided similar level of filters, level of falls from height or ground level, hip injury, population criteria, and one more filter was added after our last discussion. People wanted to see just level 1 trauma centers. I couldn't do all like level 4 and other, because at some we are showing so many pieces of information that, and some of the visualizations, the sample size was really decreasing if I do level 4. So we just decided we will just give one more option, either all trauma centers or just level 1. So that's one thing was added, but the trauma registry now shows a little bit more information than what we saw in hospital discharge database, is what percent got admitted, what percent got admitted to ICU from all the trauma cases entered into trauma registry, what was their median length of stay. So it gives a little more information on outcomes of trauma. as we can see, the deaths are 3.67% compared to what we saw in hospital discharge database. It was 0.7. Obviously, if we are talking about then in each and every falls in HDT. So then it talks about another outcome, which is head injury, and like 35% of falls had head injury in 2022. Again, if we look at the suspected and confirmed alcohol and or drug, we had 15% where the alcohol or either alcohol or drug was involved. And while looking at in that 5,000 cases, then what toxicological substance we found with the drugs, and it says alcohol was 9%, and then we have other drugs information also available. So this basically helps us kind of understand, okay, if this is the burden, what age group or a gender or what other risk factors, what outcomes, and things like that to figure out our next steps, basically future plans, like what we want, how we want to prevent it, and where we want to focus. I've seen that someone has raised a hand.
This is Sean. I just want to point out one major difference between the hospital discharge data and the trauma registry data. So the trauma registry data is excluding all, should be anyway, excluding all patients with an osteoporosis defining fracture. Whereas the hospital discharge database, I don't believe the osteoporotic patients are excluded.
Sean, that is true. Hospital discharge database, they are required. It is not for just an injury registry, right? It is each and every hospital admissions or ED patients. They need to submit data on everybody. The way I narrow it down to false is just based on the diagnosis codes. If the diagnosis codes are within and E codes are within that false, okay, that's my population. So there is no further filtering happens in the hospital. Hospital discharge database, what we are seeing right now, it's just the burden of any fall as far as it is diagnosed as falls. That's it. Trauma registry, we have the inclusion criteria. So that is based on those inclusion criteria. Assumption is that everybody is following that criteria and entering the same definition of falls in the trauma registry. So obviously that is not going to be true. Nobody's following 100% of the guidelines, on the inclusion criteria. It's not possible also in any real world. We will find some cases here and there like that. But based on the inclusion criteria, we can safely say that's the definition of falls for the trauma registry.
Thank you for the summary, Vatsal.
Any other question?
No, I think that's a great place to kind of set the stage as we go back to the diagram. Is the audio better on the mic now? Hearing no problem, so it is. So some of the questions that we've summarized from the last two meetings were specific to hip fracture data. And we wanted to summarize on this slide and then open it up to the group of kind of what they wanted to see potentially in some of our hip fracture data.
We can't hear you guys online if you're speaking.
Can you hear me now?
Barely.
Barely.
This got worse. That got worse. I can.
That's still can't hear.
I'll just use my computer for now. All right. Can you guys hear me now?
Much better.
All right, sorry. Hopefully you guys can hear us. Nope. All right, is the echo gone?
My wireless speaker.
We don't need a speaker, we just need it off any audio off on the devices here. So off from the room and off from the computers. Sorry, we're working on the audio without an echo here. All right, how about now? I like all the, All right, let's do it one more time. Okay. I think we got rid of the echo. We're going to use my iPad and we'll just pass it around the room. We've done this before, so. All right. Thank you. All right, we will make this work. So thanks for all the thumbs up. All right, anyhow, we have the list of questions that have come up related specifically to hip fractures. And so we wanted to kind of look at this information and go through some of this to figure out how we want to actually potentially make any adjustments to our fall dashboard moving forward. So one question that we wanted to talk about is just looking at isolated hip fractures and recognizing that I think there's an opportunity to really make sure that everyone understands that when you look at a patient with an isolated ground level fall with a hip fracture, that they may fall in several different buckets. So if the patient goes to a community hospital that's not a trauma center, they will end up simply in the hospital discharge database into that data set. If they go to potentially a level 4 trauma center, those patients are often activated as a trauma. And because of the fact that they're activated, that patient then is counted as that facility. If you go to a level 1 trauma center, most of those patients at a level 1 trauma center are not activated as a trauma if it's an isolated ground level fall with a hip injury. And so those patients won't get into the trauma set. So we have kind of these 3 buckets of how these patients may fall when you look at our hip fracture data. And so wanted to make sure that kind of everyone understands that there's a little differences in terms of how those patients may be managed and also how those patients are captured in our overall data set. Yes.
I'm just saying, I don't know if probably not exactly the same, but for our isolated hip fractures, ground level fall patients, we really try to admit those patients to the trauma service still, so that the trauma service oversees the management and care, knowing more of the complications that they're potentially up for. And so I guess that would be, we'd be losing those patients in this data, correct? Because they weren't activated as a trauma, even though we admitted the patient to the trauma service.
I believe so. Carissa, I know you're on the line and you kind of helped me understand how these patients are captured. Did you capture all of that online? If the patient is admitted to the trauma service with an isolated hip fracture, but not activated as a trauma, that they do not fall into the trauma set. Is that correct?
Correct. They need to be activated as a trauma, so your registrars capture it as an activation if they're an isolated hip fracture and they're admitted for them to make it into the registry.
Oh, because we do enter those patients in our registry, but I know that there's some inclusion criteria that's different for the state versus TQIP.
Yes, so TQIP's going to capture those admitted isolated hip fractures.
But ASTR does not, correct?
Correct, yes.
And then Sean, I see your hand up next.
So when Vicki Bennett and I surveyed a lot of the hospitals, what we found though is, everybody is, if you're reporting to the National Trauma Data Bank, then you're including all of those hip fracture patients if they're admitted and it's not an osteoporosis defining fracture. But what you're supposed to do is click the button that says not a state patient. But what Vicki and I found is that a lot of people are not excluding those patients and that data is going to the state. So you're going to have a mix of both of those patients unless the state is filtering them out.
I can speak to that a little bit. So yeah, I asked during one of the TROG meetings if people were using that state patient variable consistently. And it was, I found the same thing, that people had heard mixed things, that we weren't using it, that they shouldn't use it. And so we built a population with ESO. So when I go to run the data annually, it filters out things that shouldn't be in the inclusion criteria. So even though some of them are probably sent to us, we have a population that shouldn't capture those.
Thank you for those clarifications. I think the kind of takeaway that I get from this is that there are really different ways that these patients are captured, and just making sure that everyone is aware, which is really, as we try to build out this data initially, when we were first asked for hip fracture data, we actually just pulled from ASTR and then had the recognition that we were actually missing a large volume difference. So if we quickly go back to our fall dashboard, and we look at the numbers, just to kind of highlight the number difference in those two patient populations, it's pretty significant. So if you look at just all fall related discharges, and then you isolate by hip injuries and say falls with hip injury. So you see that is about 10,000. And then if you go to severe falls, you can see there we're at about 3,800. So pretty significant difference. So when we look at some of this, that was one of those pieces we want to make sure that we are painting the full picture of how these patients may be seen and kind of captured within our data set. Go back to the slide deck. Thank you. Oh, yes, sorry. So I'm for those of you who are not online, I'm walking my device around so everyone can hear Dr. Jones.
So if we go back to the charges component or the costs. So it's interesting that the median charges are 75,000 and a DRG for hip fracture is 28,000. So I don't know what the difference is of that, if it's charges versus reimbursement. For that's charges, hospitals are losing their on these, which is a whole different thing from a CMS to take care of these patients. So I don't know if that needs to be drilled down a little differently on that with that component. So that's a lot of despair. That's 3 times more. So hospitals are losing almost $50,000 per hip fracture with a severe fall.
So Vatsal, did you hear that regarding the charges versus reimbursement? I think I've seen some of that different data. If you can click on severe falls, I think we have on that tab the charges as well. I'm not sure if we do. No, none. Okay. But I think, but if you can maybe speak, I know in the past you've been able to pull the charges versus reimbursement.
And we can pull that. I do have option of, I just put the charges as one of the options in on the visualizations. But if you guys think that reimbursement makes more sense to look at it, we can put that.
Well, I think it has to look at from a public health policy standpoint that, taking care of hip fractures is a, whether 200,000 falls a year, there are 11,000 hip fractures a year. And if hospitals are losing $50,000 per hip fracture, that's a huge public health policy issue that really needs to be looked at of what's going on concerning that, because that's not sustainable for a hospital system. It also then I think needs to be looked at concerning what's the best throughput for these patients. So again, if you're a CMS patient and you're going through a hospital that has, length of stay of 8 days versus, the national average is about 4 or 5, and your discharge disposition is very different than others. Again, this is a public health policy component that's really costing the system, which is us, taxpayers, a lot of money for these patients that probably need to be looked at, outside this group, but really looking at those components, because that's not really sustainable for hospital systems or the public health of taking care of these patients.
Thank you.
Quick follow-on question to that would be, does the hospital discharge data set have payer? You know, what insurance types?
Vatsal, does the hospital discharge data include insurance, patient insurance?
Yes.
That would be interesting to look at from that policy perspective that you're talking about.
Because most of these, if you look at CMS, questions,
Do you guys think
all those other points, I think that's.
we can hardly hear?
I know, get my steps in.
So I think one thing to look about from that is going to be, you know, the insurance stats, because most of these patients, as you looked at, are going to be in that CMS range of elderly patients. But I think, you know, looking at secondary insurance and who can get things covered or not are going to be very important.
Sorry. Do you guys want to test the overhead sound one more time and see if we just speak up if they can hear us? That might be the best option.
Sorry, we thought we had a portable speaker that was working. Can you guys hear us again?
Now?
Yep, okay. I think you can hear us. So what we captured there is looking at charges versus reimbursement, and then also looking at different insurance types to have an idea of where we're actually, kind of which plans are covered. And it looks like we do have access to that data from what Box is saying in hospital discharge database.
Right. So is that something we want to see it on the dashboard, or we are talking about just doing some analysis on the side and share it with the group?
I think the request is to have that on the dashboard, looking at, and also, do you get length of stay data in that, Botsel?
Yeah, we do.
Okay.
Yeah, so I think something to look at would be charges versus costs, which I think are going to be difficult. We kind of know what the national average is for DRG. I think that we then need to drill in terms of secondary insurances. And I would do isolated hip versus, I think you had associated injuries with the hip, and look at both of those from a charge component and length of stay component. So if you look at a hospital stay is about $3,000 no matter what. You know, going through the ED and so forth, especially a trauma activation is going to be another 25,000 on top. It's a different one component. But I think looking at those separately, isolated hip with associated injuries, and then the insurance status, secondary insurance, and then length of stay, I think again is going to be something that would be very helpful from a public health policy standpoint of, you know, sustainability, really cost to the system as a whole. I think those are going to be really important types of things to look at.
I mean, we can look at it, all those things, but the way you are describing it with trying to look at it in several different ways, putting that on a dashboard is not on a public dashboard. I mean, it looks like for me more of a research question, you know, so that we can look at it at many different angles, and we can do a different report. But putting everything, all those what you described in the dashboard, does not look like that is achievable, you know.
Of course, we can do that separately, taking a look at that outside this group, because I think that's, again, a different subset of what this group's looking at. But I think, you know, for sustainability for a public health issue, I think that's very important. Again, if you look at those numbers, 11,000 patients a year, that's a large number.
Right, and I can definitely prepare that kind of a report, for our next meeting. Yeah.
Yeah, thank you.
Thank you, Vatsal. Sean, did you have a question still?
Not really a question, just when Vatsal's looking at this, if we can also include in that separate report the discharge disposition and break that out by payer. I think that would be good information to have.
Got it. Discharge disposition by payer.
Fortunately, a lot of those patients discharge
I think we have lost the sound again.
status. Active. Health, home health, it's one more. Isolating home with dementia. Still there, so okay.
All right. I think we've got a good kind of started some additional elements to look at with that in regards to another report. If we can go back to the slide deck and look at some other questions that came up regarding hip fractures. That is Sean. Yep.
Dr. Bradley, then the way I would like to, I mean, if you guys are ready with me, a couple of people, then I would need their input while I'm preparing the report, and what else to include and what it will need some refinement. So I might be contacting you guys again while preparing the report.
Sounds good. I think I can volunteer Dr. Jones and Sean.
All right, sounds good.
All right. So some of the other questions we've touched on briefly, as well as looking at comorbid injuries. So if someone has a ground level fall and they have an associated head injury or rib fractures, looking at that patient population, is that a different patient population? Is that someone that should potentially go to a higher level of care versus just at the local community hospital or level 4, just with the associated care that's often needed for those patients? And so some of those questions are when we're looking at comorbid injuries. I know we have, with head injury specifically, but many of these patients may have a secondary orthopedic injury. Oftentimes they have rib injuries as well, and those can be pretty significant for an elderly patient. And so what are the other factors associated? So I wanted to get feedback from this group regarding that and what they wanted to see.
Yeah, I think ribs are important. I mean, ribs, an independent factor for morbidity and mortality alone. I mean, if you're a 70-year-old with rib fractures, I mean, your morbidity, mortality is enormous. Your length of stay is enormous. Just independently, and with a hip fracture on top, so you got 2 areas of pain, 2 areas to mobilize, length of stay, discharge disposition. I mean, those are very important type of things. It also gets along with the pelvic ring component because they can have both. Mm-hmm. And some people call it a hip and it's a pelvic ring. I mean, those are all very high, 6-month mortality type numbers. 20%. You look at it for 6-month mortality for hip fracture alone. Those haven't changed in 60 years.
Well, and I think also if you look at other extremity fractures, for instance, if you have a pelvic fracture and you have an arm fracture, that completely changes the possibilities for discharge.
Yeah, that's a smart point.
Mm-hmm.
Did you have something else, Tammy?
I just have jotted down some notes and questions of things that I wanted to be able to share. And one of the things that you're just speaking of is like, are these patients coming in as a polytrauma or strictly an isolated hip injury or just isolated injury period? And they typically do end up being the hips. Also looking at, is there a way to include their ISS or AIS scores with these? And then also wondering, like, are the outcomes of these patients, do they vary, like based on where their initial receiving facility is? So are their outcomes different if they're being taken to a level 4 or a 3 versus a 1? What do their outcomes look like when you compare them?
And that was actually one of the things that we have come next on the list to look at is it possible to look at outcome data for these patients depending on destination choice?
And then something else I was gonna suggest, and we don't even capture it in our registry right now, but as the new guidelines and everybody's getting them on board with the ACS, and you know, I think we're all trying to do this frailty screening on our geriatric patients, looking at what does that frailty screening look like in comparison to these patients, because it's really looking at their pre-function or their pre-injury function and versus where they're at in the hospital, and because it can really determine to help make a decision as to your disposition. If they're already coming in frail, trying to send them to an acute rehab is probably not going to be effective. It may steer you more towards that skilled nursing facility. And so, you know, looking potentially having that information would be great too. But again, we don't capture that in our registry right now, but maybe as we are building our new registry, that could be something that we could consider.
Carissa, anything to add in terms of, you know, we're somewhat limited in terms of what is in ASTR, but I know one of the things that, you know, requests that I had brought forward to STAB was looking at fentanyl use. That's not in ASTR, but recognizing that that is a huge issue for many of our patients with other trauma mechanisms, probably less so with some of our elderly fall patients, but just looking at, you know, how do we find where some of these other factors are that we could potentially capture that data, and how do we capture that data if it's not in ASTR currently?
So we're looking at ISS scores. Is that what the question was?
That's actually, that's gonna be the next slide we're gonna go to, so we can go to that one, which was kind of how do we define severe falls? So that was a good kind of setup for that, is looking at kind of the pluses and minuses of different formats. So one of the things that Voxel was able to do very easily was the question we had at the last STAB meeting was, what about looking at level 1 versus all other level trauma centers? So she was able to make that adjustment quickly in our dashboard. There was also discussion at the last meeting of, do we look at the injury severity score? But there are some data limitations. So maybe you can speak to some of the data limitations with the ISS. Just to help kind of guide why we chose, at least for now, to utilize the level 1 versus all other levels.
Yeah. So ISS scores, we have an ISS score for every patient in ASTR. The difference between the level 1s, and I won't just say level 1s versus the others, but those who submit a full data set versus those who submit a reduced data set. Usually the lower levels are, the people coding them are not designated registrars, and they use their billing, coding and diagnosis for their patients that they record. And sometimes they may not include, you know, the contusions or the lacerations, which is they add on those points, and so that affects their ISS scores. I'll also say that we use the ISS scores that are generated from our ICD-10 codes, which is, it's the best fix we have, because the reduced data set doesn't code AIS scores, so the ICD-10 scores for ISS are a little bit different than they would be if we got it directly from the AIS coding. So there's some debate whether or not they're lower than they would be if we use just AIS coding. So that's just not to say that it's not helpful or useful when looking at falls, but that's just some of the background with ISS scores. Hopefully that's helpful.
Yes, thank you, Carissa. So that was one of the things we talked about, is if they're not necessarily all getting counted the same way from an ISS, is that all equal? The other thing that we talked about is, you know, theoretically, if someone goes to a level 3 or 4, they're identified as having a higher injury score, they're likely going to end up getting transferred to a level 1 trauma center, and it's going to get captured in that data set anyhow. Now that would be captured as a secondary transfer, so that facility would count that patient as a transfer in, but we would still capture that patient in our level 1 data. So that's what we felt like, even though, at least for now, looking at some of the limitations with the ISS, that utilizing level 1 should capture everyone that goes, even if they go first to a level 3 or 4, but is found to have significant injury, they're still going to get into that level 1 bucket. So wanted to get feedback from the group and kind of why we made that kind of decision. If we can go back to the fall dashboard and look at the severe falls. And then you can see there, so the severe falls currently lists all trauma centers. That lists four levels 1s, 3s, and 4s. But then if we go and adjust for the level 1s, you can see how those numbers change. And so kind of recognizing that some of those differences with that as well.
One like the day last one. Cost of the healthcare system is different. So taking a look at the data, looks like the length of stay is already 1 day less for going to a level 1 than any other center. And if you look at the data also that, you know, time to surgery should be less than 24 hours for hip fracture for outcomes. So it'd be interesting to see, you know, a lot of level 1s will have dedicated rooms 7 days a week to take care of all patients versus community center or level 3 or 4, which doesn't. And it'd be interesting to see the time to OR, which is again, national standard is less than 24 hours. If that is affecting your length of stay outcome and potential true outcomes of disposition, morbidities, 6-month mortality, and everything else. That's a huge deep dive. But that's interesting that just looking at this alone, that there's already one length of day less in the hospital at a level 1 versus a level whatever component. And that may be due to also, you know, care management's better, throughput's better, importance or priority of these patients is more for the centers. So, you know, again, it's a deep dive and there's probably not all the data there to make any inferences or trends from, but that's interesting already on the big dashboard that you see that.
Also, would we have any access to the data in regards to time from arrival to OR time? I don't know that in terms of what we capture. I don't know that that would be in the hospital discharge database.
Arrival to.
So when they get their operative repair of their hip fracture, because the goal, pardon?
No, not in hospital discharge database. Hospital discharge database, we have only 2 times. One is the date of admission and date of discharge.
Right, thank you.
Can you go back to the Alzheimer's search to look at that?
You should just go sit next to them.
So I'm just taking a look at also the other components is the head injury being actually more. If you look at the numbers, 8% versus 6% of the all, you know, non-level 1 centers is also an interesting component. And that would convert though, if they went to a level 4, then transfer to a level 1, would that be considered a level 1 for the care of their patients? Is that correct?
I believe so, Voxel, just to confirm, if the patient goes to a level 4 and then gets transferred to a level 1, they would end up in the level 1 bucket, but also the level 4 bucket, correct?
Yes.
So theoretically, it's odd that non-level 1s get more polytrauma hip fractures than level 1s, which is really odd. That should be the exact opposite. What's that? Yeah.
Higher. So we've got the mortality. So we've got the deaths and outcomes. So right there in the center.
And then if you go back to all, is that if number increase. Slightly.
Yep.
So for those online, if you can hear, just that was looking at the mortality rates for deaths and outcomes for level 1 versus all trauma centers. So also, you know, also recognizing that in parts of the state, there may not be a level 1 trauma center. So that's going to be potentially a patient getting transferred out of state, depending on where your closest level 1 trauma center is. Yep. And then also potentially getting just to your closest trauma center who can stabilize that patient and then send them to a higher level of care. So many times, quite a bit of our state, it would be very appropriate to go to your closest hospital versus flying every patient just because of the resources and risk associated, and then weather limitations as well, different times of year. So some limitations with
Yeah, but
that.
it's kind of interesting. I mean, if you look at the data nationally, like, and we're level 1s and 2s combined, but, and this has been from older data, level 1s and 2s versus others, that a pelvic ring is death at a non-level 1 center is like the number one most highest cause for preventable death. In other words, they're underdiagnosed with these associated injuries for an older person, pelvic ring or not, versus going to a level 1, which is interesting. Again, the mortality's higher. Again, the deep dive, other things involved and so forth. But again, if you're going to a non-level 1, you have a higher mortality. Again, how do we nudge this to get best outcomes for patients concerning that? And that's, not going to be decided today.
So kind of seeing some of the limitations, is the group comfortable with kind of the way that we have at least, current screening for a more severe injury is utilizing the level 1 trauma centers, but recognizing that that's just based on destination and not necessarily ISS, which might be why we're seeing some differences. So I don't know, Boxel, without giving you a ton of extra projects to work on, do we look at ISS versus level 1 and see if those comorbid conditions where we see it doesn't seem to make sense that if you have a comorbid, head injury and hip fracture, you would think more of those patients would go to level 1 versus non-level 1 facility. Kind of seeing, is that because we screen by the level of trauma center versus ISS? So just to kind of touch on this last question, which is how are transfers counted? So I think that was, Voxel did clarify. So a transfer between 2 trauma centers would be counted twice because they're going to be counted in the level 3 or 4 bucket where they went to initially, and then they would be counted as a patient when they arrive at the other trauma center in that denominator as well. If we can go to the next slide. So I know Dr. Pfizer-Vaughn had asked some questions regarding brain and spine injuries, which we kind of touched on a little bit here. And I think looking at some of those comorbid conditions. So one of the questions we had was what conditions are we looking to capture? So we have seen some other things here, which actually weren't brain and spine related. So we talked about rib fractures, other extremity fractures. Are there specific, it's easier often if we can have diagnostic codes. A concussion can be a very generic term. It can be a simple bump in the head and the patient has no comorbidity related to that versus someone who has a subdural or subarachnoid. And so recognizing if we just use the generic term head injury, does that maybe capture a lot of patients who may not actually have a significant head injury versus someone who has a true intracranial hemorrhage or a concussion with significant, clinical findings after that incident? So kind of looking at what conditions do we want to potentially include and looking at then how does that affect some of our comorbidities and length of stay, discharge options for many of those patients.
Well, knowing the limitations of the trauma registry data, because a lot of the level 4s are not reporting the full data set, this suggestion may not hold water, but you might want to just look at your AIS code body part, for 1 for head, and then the severity for that part would be 2 or higher. The problem is, I don't think you can get that for every patient, because if they are not reporting AIS codes in the level 4s, you may not have it. I'll have to rely on Carissa and Boxel to tell me if that's possible.
Yeah, we wouldn't be able to have that for the level 4s because they don't submit those codes, like you said.
But presumably if it's 2 or higher, that's for level 1, which is not left anyway.
So, but presumably if they're a level 2 or higher, they're gonna be transferred out of a level 4 and be captured in the level 1 bucket anyway.
Yep. Yeah.
So I think that's definitely an interesting point of how we look at that, and potentially to the point of, if we're looking at a billing code, seeing how sometimes someone diagnoses a head, like, ground level fall, someone bumped their head and has a hip fracture, your billing codes may be right hip fracture and head injury, and the head injury may be simply a hematoma, but you have technically struck your head, you had a head CT, you qualify for that diagnostic criteria from a billing perspective, which might be why those numbers are higher in the level 3 and 4 centers versus secondarily in a level 1 trauma center where they may be looking at a head injury as this intracranial hemorrhage or something more significant. So trying to kind of tease out where some of those differences may be. Certainly looking at cervical spine injuries, especially with the elderly patient population, when they have sometimes a minor mechanism and then get a second a cervical spine fracture. I know that's been a lot of the conversation when we look at elderly patients with ground level falls. Do they need a cervical collar? In the past, those patients all got collar and backboard. Then we went kind of at the other end of this we swung the pendulum across, and now recognizing that some of these patients do in fact have cervical spine injuries and probably need to get that collar on pre-hospital. So do we need to, would that be an interesting patient population to look at, which is cervical spine injuries related to ground level falls? So I don't think right now that we're capturing that data. And that is a very large patient population. And many of those patients don't comfortably fit in the pre-hospital collar. I would say it's, when we get these patients in the hospital, we put a cervical collar on. It's a very different cervical collar than the pre-hospital format. And it's much more comfortable for the patients, and many of them tolerate that versus what is available in the pre-hospital setting. So I want to see if there's interest in looking at that.
I think one that's going to be underdiagnosed is going to be vertebral spine injuries, especially again in these older patients that have concomitant, acute on chronic vertebral compression fractures, because again, that gets into osteoporosis and all the rest in these patients. And I'm sure those are underdiagnosed, but will affect outcome independently, since each spine fracture is an additive morbidity and mortality versus just a hip fracture is a single isolated morbidity and mortality. So if you've had 4 or 5 vertebral compression fractures, your chance of morbidity mortality is much higher than just one. So again, this is one that really affects your comorbidities, probably your discharge, your frailty index, and all the other things. And we probably don't diagnose that or image enough to figure out what those numbers are, unfortunately.
So as I'm kind of hearing all of this, we kind of keep circling a lot back to the elderly patient population, the frailty index. Do we potentially look at a geriatric dashboard that maybe captures some of this as a separate entity? That might be something that we can capture some of these elements in. Dr. Gamer, I see your hand up as well.
Oh, I think you addressed that with your comment about a geriatric dashboard, but I do think that's very useful to look at the concomitant brain or head injuries and spine injuries because when you're taking communications from the field, that figures into where you send patients. They may have just what appears to be an isolated hip fracture, but they're frail, elderly, and we up triage them preferentially to level 1 centers in a lot of cases, especially when it's 6 of one, half dozen of the other transport times and distances. So is that a flawed logic that can maybe be studied through looking at the what happened with the patient? was the patient taken to a level 3 or 4 facility and then transferred because of a spine fracture, neck fracture that wasn't evident in the field? Thank you.
Thank you, Dr. Gamer. I think many of these patients actually go to also community hospitals as well, right? So many of these patients may go to a non-level trauma center. So this is going to be your local community hospital because they're ground level fall. They don't meet any trauma activation criteria. So they go to simply the closest facility. And so that, you know, recognizing how do we identify some of these other patients? One of the things I did bring up as well, and I wanted to make sure that this group, as we look at kind of all of our data and we look at brain injuries, the assumption is that all intracranial hemorrhage and brain injuries are going to be at a trauma center. But we do actually have at least one facility in the state that has neurosurgery, manages intracranial injury, and is not a trauma center. So if a patient ends up there POV or potentially as a transfer in, that patient is going to end up in our hospital discharge database, but would not end up in ASTR because they're not a trauma center. So just, you know, kind of thinking we have a diverse hospital system across the state and many different ways that people get care. But just wanted to point that out to people that as we look at different facilities, there's different ways that care is provided across the state as well. So I'm going to come over there just so they can hear you online.
Are being better about asking about if they're on blood thinners, then I feel like they're making the calls to take them to a level 1.
Okay, so can you say it again? Sorry.
That if they're on blood thinners, I feel like the EMS crews are getting better about asking that and then making the call to their level 1s. Yeah.
So I think that is another slide that we're going to go to. I think maybe next one as well is looking at the anticoagulation and how that kind of also contributes to potential morbidity and mortality as well. All right, do you want to go to the next slide, Shelley? Yep, there we go. Falls in anticoagulation use. So this is something that is a little bit trickier. So thank you for Carissa for kind of the quick data pool that she added here with some of our numbers. So how reliable is anticoagulation use captured? So if you look at this, there are, for 2022, there are 68,000 records and just over 10,000 patients had anticoagulation use captured as a comorbid condition. But this is specific to ASTR. And this is if the full data set is submitted. So again, at level 3 or 4 may not, some of them do, but not all level 3s and 4s submit the full data set. So just for those facilities that submit a full data set, you can see a very large percent of these patients are on anticoagulation. And then one of the things, unfortunately, we do not have any way of pulling that from hospital discharge database. So that is something where the way physicians do the med reconciliation, it's not something that's captured as a billing criteria. So unless someone adds that as an ICD-10 code, it's not something we can capture. So we can only get this data very specifically from ASTR. So from that patient population would be specific to the trauma centers. But definitely looking at, you know, anticoagulation use with the new triage guidelines pushed out from ACS is definitely a factor. But it's something that, as you pointed out, many crews really are asking that question more. But a pretty significant difference there in volume. So currently on the EMS judgment, so if you kind of look at the new ACS field triage guidelines that came out in 2022, you've kind of got the top 2 boxes, which is your highest level trauma center, your next 2 boxes below, which is kind of the yellow category on the ACS guideline, which is kind of the consider taking to a trauma center that's most appropriate in your region. And then on the EMS judgment section is the anticoagulation use. So, you know, the question that came up is there a difference in mortality rates? I don't know that currently we've looked at specifically, Vatsal, maybe you can clarify if we have or have not. Have we looked at mortality rates for patients with anticoagulation use versus without? For all comers?
No, we haven't looked at it that.
So that would be something that I think might be useful just to add to the trauma dashboard, is looking at anticoagulation just in general, because whether it's an intracranial injury, they have, you know, motor vehicle crash and have chest injury, abdominal injury, all those patients, if they are on blood thinners, are going to have, I'm presuming, a higher risk for morbidity and mortality associated with that. So that would be useful. Maybe we can add in mortality rates within,
Especially for maybe an education.
Okay.
But, the educational. It's actually nice. Is that something that educate?
Yeah, mine is too.
all right, can you guys hear me? We lost internet for a second. Okay,
Yes. No.
Vatsal, I see your hand up.
What I'm hearing is that we want to see actually several variables around the anticoagulant use. And we are talking about all trauma patients, right? Not just falls. Is that right?
Correct. Yes.
Then I would say if we are looking at several features to look into patients who are on a blood thinners and what is happening with them, what kind of injuries and things like that, do you advise that we do a one-pager visualization just on blood thinners?
I think that would be helpful to look at, looking at, and I see some head shakes in the room here, just because there is a pretty good percentage on when we look at just the full data set facilities, what are the numbers?
Correct.
So I think that would be helpful to have looking at more just anticoagulation use and mortality rates.
Right, because right now what all the dashboards we have, they are mainly give more based on the demographics and give the overall picture of particular injury or overall trauma. I think this will be more of a clinical outcome related visualizations, and we can start creating some of those kind of dashboards.
That'd be great. Thank you.
Yeah.
And then the other question I think for Carissa was just when facilities are utilizing the ICD-10 code for anticoagulation use, do you know which one they're using? Is there one specific one that's used kind of universally, or is there different ones that you see used?
So we don't really ask them to capture that because it's not an injury code. We only ask them to capture the ICD-10 injury codes. They capture that in a different area. It's an NTDB data element where they capture the comorbid conditions. So we wouldn't really ask them to do that.
So it's captured as a comorbid condition, not necessarily an ICD-10 code?
Correct. Yeah, it's just a pick down list right now, and that's it's updated by NTDB, and then we usually adopt those changes. There's nothing keeping the registrars from coding that in ICD-10, but it's just not something that's really written into our rules or that we provide education on.
Okay.
Maybe something to educate people because we will be reimbursed more if you know, and then it's probably an easier way to count that condition. Sorry, I'm getting yelled, put in some miles today. I think it may be something that is caught in a different area, but it may be something to educate people because clearly this is an important comorbidity type factor to have, and it probably does affect length to OR, bleeding, hematoma, maybe anemia and so forth, and that therefore may affect discharge disposition. I think educating people on, geriatric fractures, which is a separate ICD-10 code, and anticoagulation type code, is probably going to be easier for people from a metric standpoint, but it's also going to be appropriate from a reimbursement standpoint, because that does probably pad your DRG, and you are going to get paid more as a hospital for those patients because they truly are more complex.
And Carissa does a lot of education with the TRUG group, the Trauma Registry Users Group. So that may be a great option to do some education with that group about kind of some of the benefits of capturing that data, especially if it helps with reimbursement. So thank you for that added piece there.
We can always add on. I mean, we did that with COVID, right? The registrars captured ICD-10 codes for positive COVID tests and that kind of thing. So that was out of the realm of just capturing the regular trauma diagnosis injury codes. And so if the state wants to do that, we can always kind of make that, I'll say, a special project we're doing to have them look for that and capture it. But it would, we would need to have, everyone educated in level 4s, because level 4s could in theory provide that as well. So yeah, we can do it. It's just something we would talk about, and it's possible. It's just not being done right now.
Thank you. And I think especially as we look at, overall challenges, especially for many smaller rural facilities, anytime you can potentially increase reimbursement, that would be helpful. So if that's something that increases your reimbursement for a smaller rural facility, that may be something that is a beneficial thing to add from an educational perspective. All right, so I think we have addressed the fall and anticoagulation use. We can go to the next slide. So Sean, I did include a slide on this. I know you had lots of great questions about kind of lift assist calls and kind of how do we define this? Is there a way to capture this? And I know you're online, and you and I, we had quite a bit of discussion about is it possible to capture this patient population? And some of the questions that came up at our last staff meeting is, this is often an index fall for subsequent injury and illness. Incidentally, I had my last clinical shift, 2 ground level fall injuries, one of whom it was COVID this week. So that was why they fell, was essentially they had COVID. And the second one was a STEMI and influenza A. So both this week. So when you look at just these were both ground level falls transported by EMS that had, a viral illness, and one of them had a significant comorbidity at the same time as this. But recognizing that these ground level falls are often that index fall for something more significant. And I think one of the things that we looked at is, how do you identify these patients? One of the things I do a lot of training on with EMS is these minor fall injuries. With my own father, he had a ground level fall, and the phone call I got after midnight, the crew did vital signs and identified bradycardia, and he actually was in a complete heart block. But recognizing that, there's many high-risk medical conditions that cause someone to have that fall. And so it really takes the education focusing on assessing these patients, doing vital signs, getting them up and standing them, making sure they're able to stand on their own if they can normally or can't. And then also ambulating them, try to see if they normally ambulate and now you stand them up, they can't ambulate. Well, that means they probably have something more significant going on. So I don't know that we can, from the limitations of how these calls may or may not be submitted to AZ peers by different agencies, I don't think there's any way we can capture this patient population from AZ peers, but I think there's an opportunity to do a lot of education to EMS. So we have started with some of that, which we can kind of link to that training as well. But I didn't want to ignore your question, Sean, so I did put a slide up regarding all of this, because certainly I've seen kind of with my own family, and I think many of us in this room have seen that, that these can be significant incidents with significant underlying illness and injury associated. I'm going to come around and then I'll open up to any of the questions.
I know you guys had spoke that this would be hard to kind of define and determine. Is there a way that we could capture patients who have fallen previously to show up? Because sometimes, data shows if you fall once, you're 50% more likely to fall, and then those become more significant. Typically, is there a way in our data that we are able to see patients who come in with severe falls but have been seen previously with falls before that may have been discharged home, looking at the data, most of our patients are discharged home. From an educational and injury prevention, I think that's where our opportunity of improvement could be. And this might not specifically hit to completely the lift assist calls, but might be able to capture some of them that come in, that nothing was found, they were discharged home, but those are the patients that we really need to kind of identify and hit and target with our injury prevention standpoints so they don't come back.
Again, there's an ICD-10 code, but I never knew for that. It's
Good to know.
91.81.
Okay.
I mean, again, this is, it probably is, again, an education component because it truly does affect your disposition, how they go through the system. It's not gaming the system, but it's also something that pads your DRG from a reimbursement standpoint. And as you stated, I guarantee you that this is not their first rodeo of a fall.
No.
And I think it was getting to Sean's component too, that it would be real tough is, these people that get seen for a fall, do we have a follow-up of, someone goes to their home, you need to get rid of your rugs, you need to, those are all, again, that's public health policy. The cost of someone doing that is there, but also the cost both physically and monetarily for an ED visits and all the rest is not small in addition.
But if we were able to capture that data and therefore show the significant need, those of us who worked or have worked before, we know that that's what we see. I just can't find any data to kind of show that. So I don't know if we're able to, or now good to know there's an ICD-10 code. Sorry, Carissa, I feel like you're going to have a lot of education. But and that's for other people. You say
If you're looking at the dashboard and the high level numbers, if you're looking at non-hip fracture patients and they're dispositioned from the hospital, from 87% are discharged home. 100%. So drilling down on necessarily who those patients are is probably a hospital, level for your trauma database and what you can flag in your system, which is what we try and do at where I'm at. But then also from the EMS perspective, I think there's a huge opportunity for our agencies that have a community response system in place to involve their social workers and their care managers and their community outreach team at the first call. Instead of, at the lift assist call level. We may not be tracking the lift assist calls, but we need to get EMS crews to recognize that the first lift assist call is when they start asking for assistance from community response, not waiting until they get 5-6 calls later at 2 a.m. and they're sick of the 911 call at 2 a.m. and we need to get somebody else involved. So I see that as a huge prevention opportunity, even without the data. Just kind of another element to training is if you have that capability in your agency, how are you using those specialists that can get a PCP referral and can get home health out there to do some home health PT and OT and do a home check before the next 911 call comes in?
Yeah, I think it falls on. That's exactly what this dashboard's here. And you look for other things such as cardiac components or paroxysmal, AFib, all the other weird things that come about, why they fall. I mean, how many times do you fall this year? Like 0 for this room. There are other reasons why people fall. And then you look at the downstream components, it's enormous for, again, physical costs and monetary costs of the system.
Yeah, so one of the things that we're doing out at Gila River, because we do have our mobile integrated health program, is we're actually, I have even a spreadsheet in front of me now, or the PDF in front of me now, where we actually pull all of our lift assist calls from dispatch. So we grab that data first, and then we have all of those charts pulled through our QA/QI review on, and how many of those have actually, if there's especially repetitive ones, we want to get our crews out there and get all of those resources, which is nice to have an MIH program where you can integrate all of those resources, the home health, social work, all of those things, to be able to really address this issue. Because this was something that it's not that it hasn't been on our radar, but it's something that we put on our radar over the past year, and we're beginning to track it exactly and trying to get in with those very first calls. So I don't know how many programs you guys have in, I know Tempe and some other places have some EMS programs that could maybe integrate right from the get-go, pulling that data from dispatch centers, looking at those charts on their QA/QI and seeing which ones are appropriate to go evaluate them to integrate all the other resources that are in the community with them.
So, and I won't put Monica on the spot, but I can speak for agencies that have done community paramedicine programs. They are very effective. And many of the pieces that I've educated on with those programs are specific to fall injury prevention and kind of basic interventions, you know, going in, assessing the home, rolling up those area rugs, looking at oxygen tubing, cords. The problem is a reimbursement. We know who saves money, and that's the payer. Unfortunately, it's getting anyone to fund these programs. So unless a municipality has funding to support this, I think that's one of the bigger challenges is getting this to be a funded process for many programs. Monica, I don't know if you want to speak to that.
Yeah, that's what we're having trouble with right now is funding actually. And then the other problem we have is even if we do get referrals, well, when we get referrals, getting them hooked up with a case manager, either through insurance or a social worker through insurance is very difficult. Those social workers and case managers have upwards of 150 patients each. So they get put on a list and a lot of times they either fall multiple times again or unfortunately they pass away before somebody can even get to them for help. So I think that's what we're struggling with right now.
So, get you steps in. So just to make everyone kind of aware, because Gila River Healthcare does have access to all the patient's data on all fronts, we have been working actually with Access and putting together pro forma to specifically do that and create remuneration for different levels with them. And we're hoping that once we, because we're actually in the process right now of creating our pro forma and putting all those different levels of care with them, because we've shown them with the actual data and the readmission data and all those things where we're actually saving the payers a significant amount of money. So they're excited about that. We're just trying to really put that together, and once we can get that out there, we hope that those same levels of like what we're calling our mobile integrated health community paramedic program care, those levels of care could then be utilized by other programs too, because it's been proven as a, you know, because we have all of their billing data, their hospital data, discharge data, what they ate that morning for breakfast, we have like everything. It helps give a very clear picture about how advantageous these kind of programs can be. So we hope that that will translate to other community paramedicine programs also being able to bill access, because in the long run, it's actually not only saving the patient, time and energy and effort and letting them spend birthdays and Christmas and holidays or whatever at home, but it's also saving the taxpayers money, saving, things in the long run. It truly does. So because we have demonstrated that, now we're trying to get through the pro forma. What are the actual costs involved of coordinating a system like this to be able to do that? So we're in that process right now. We have met with we've met with Access a couple of times, and so far we've gotten a lot of really good feedback from them. So because they can see it on the billing side very clearly.
So I think to the different kind of patient buckets, and I know Ann has said, when we look at the AZ Peers data, so for those of you who may not be familiar with AZ Peers is all of our EMS charts. So when an EMS goes on a call, they put their the documentation for that call into their electronic patient care record. That goes to AZ Peers, which is our statewide EMS registry. So there really is no way for us to capture lift assist type calls in that data set. And the reason is different agencies document these calls differently. And so some agencies, it might just be a patient assist or a community outreach as opposed to an actual patient care record. So I think the opportunity that I look at with this is educating EMS, kind of really talking about why these patients need a full assessment. So recognizing, these patients need a set of vital signs, you need to evaluate them for injuries, make sure you stand them, make sure you ambulate them. If they use a walker, get their walker for them. So number one, just treating them as a patient, I think is opportunity for one to talk about all the different things that cause people to fall. And so I think that's where we probably have more of the opportunity from an educational perspective. The next component with that is looking at some kind of fall injury prevention. So I like to tell EMS this is EMS prevention. So we know fire prevention was very effective of decreasing the number of fire incidents. So if you don't want to go back to this person's residence at 2 a.m. again, if you see that they tripped on an area rug that's next to their bed, offer to roll up that area rug. So some basic interventions that you could potentially do on that call to help prevent them having another fall. And so we did, with the education committee, put together some training resources that really addressed a lot of those things. But I think as an EMS agency, one piece you can do is to really, those are going to be a lot of your refusals. If crews know that you're looking at those charts, they're going to recognize, hey, I need to make sure I'm doing all these things because my agency's looking at these patients. Or to Dr. Southwell's point, they're looking to see, was an assessment done? Because we do recognize that this one fall, even if that patient refuses, they're not going to get into any bucket of hospital discharge database or ASDR because they stay at home. And so this is a very large proportion of EMS refusals currently are those patients that go out as kind of a minor fall injury or lift assist type call. So that, what kind of a limitation of recognizing how do we address that patient population? I think that's really giving that education to EMS. Sean?
I think that's an excellent point. And I think the problem with the reimbursement is the universal problem. But with the data that we are working on right now, I think, to Gila River's point, this is exactly what I want to ultimately accomplish, is going to the payers and saying, we can save you money, and we can save lives, and we can give good quality of life back to people who otherwise would waste away. If we can show them, hey, community paramedic programs, community health programs will prevent these injuries or the severity of these injuries, we can save you money. Will you help fund these programs? Will you give us grants? Will you help pay for people to access these services? The other problem that we have is in the very rural areas, you're not going to have a lot of resources for fall prevention, and you're probably not going to have a lot of community paramedic programs. So then we have to get creative. What can we do? Do we have maybe people that can do matter of balance classes in their communities? So I think pie in the sky view is this data is going to be super helpful long term towards going to payers to say, we can save you money. We can make a difference with these patients. Help us financially. That's my point.
Thank you. And then Melissa? And I know from really in the last, I would say at least 7 years now, there have been several community paramedicine programs that have worked with Medicaid and other insurance companies and have demonstrated cost savings and the cost to maintain these programs. And while everyone has been very excited about the cost savings, there has not been the reimbursement to sustain this long-term after an initial grant opportunity. So I think that has been one of the challenges for many EMS agencies. That many of these programs have existed. They've been in place. They have demonstrated cost savings. They've also demonstrated the cost to actually maintain this. You don't need this 24/7. You really need this even just a few days a week to have someone follow up with these patients to do some of this work. But unfortunately, it's just not something that has gained traction from a reimbursement standpoint. Melissa, I see your hand up again.
Sorry, I forgot to take myself off of mute.
Oh, not a problem.
This is Melissa Luxton. I'm the Trauma Outreach Injury Prevention Coordinator at Banner University Medical Center, Phoenix. I'm also the chairperson of the Arizona Falls Prevention Coalition and the chairperson of the newly developed Injury Prevention Alliance of Phoenix. So I just wanted to share a couple perspectives. I've been in the injury prevention field this is my 8th year, going on my 9th year of injury prevention. And falls has always been my #1 injury at my center, just as it is everybody else's. And I've been really taking a deep dive over the past couple of years and trying to look at fall prevention because there's all these efforts going on and the numbers just seem to constantly increase. And not to say that, yes, absolutely Tai Chi, matter of balance, those things work. They have been proven effective. They're evidence-based programming. However, the typically the participants that are participating in those, they're not falling. It's not our vulnerable population. There are active seniors that are going to senior centers. They're still hiking, they're going for walks, they're working out. It's not the vulnerable population that continuously falls, and it's our repetitive calls. So looking at that information, I kind of just took a step back and said, you know, what's worked in the past? What are some massive injury prevention campaigns that have gone on that have been extraordinarily effective? Two that I think have been, at least in my lifetime, the most effective. One is seatbelts. Back in the 1980s, we had seatbelts and nobody was, I mean, I rode in a Escort in 1987 all the way to Florida from Michigan at 7 years old without in the back of a car. And it was no big deal. Now a parent would never dream of doing that. And why? First, massive public service announcement messaging on a grandiose scale. Second, financial incentive. So click it or ticket events. When there was anytime there's financial incentive to changing a behavior, it tends to stick. And then most recently, COVID. So looking at COVID, I think we can all agree that if you're out in public, the amount of people that used to wash their hands in a public restroom compared to the amount of people that do it now has definitely increased. Why public service announcement messaging is effective, repetitive messaging, constant education, everywhere you look. Now, when we talk about fall prevention, we haven't done anything like that. In fact, a lot of the places I go to, when I go to communities, they'll be like, okay, we're going to list your event, but we're not going to tell them it's fall prevention because they won't show up. So there's this like negative connotation with fall prevention education out in the community. Our older adults don't want to attend the classes. They highly correlate that education to a loss of independence. They're worried that if they admit that they fall or if they get education on falling, that somebody in their family is going to put them in an assisted living facility. It's admitting defeat. And so how do we change that perspective? How do we change the way that our family members are looking at falling down, the people that are falling are looking at falling down, and letting them know like this is a common problem and we need to be aware of it. So that's kind of the stuff that I've been looking at in the realm of fall prevention.
Thank you, Melissa. And we are going to get to a slide, I think, on fall prevention as well. So I wanted to just kind of, to close the loop on this piece, I think that this is something that we can really address just from a data perspective to kind of explain why we can't necessarily capture the pre-hospital data very accurately or consistently. But, you know, certainly individual agencies can really work to improve this. And as a base hospital, you can work with your agencies as well to hopefully improve some of this care on scene. We can go to the next slide. So I am glad to see we've got two of our PACES representatives here. We have, I believe, Dr. Woolrich. We also have Abriana as well from the PACES perspective. So when we look at pediatric falls on our dashboards, as a reminder, if we can go back to those, we do have specifically kind of the carve out to the 0 to 17 age group for both all falls as well as the severe fall patient population. And recognizing that, you know, there's different injury prevention things that we look at with pediatric patients. So we wanted to make sure we talk about pediatric patients. If we can scroll down a little bit. And is this the 0? You see they're obviously much higher age group in the young pediatric patients, the 0 to 4 years of age. And then quickly those numbers go down, obviously much lower substance use related. And then the mortality rate, fortunately, is quite low with that. But recognizing that falls are an issue in the pediatric patient. If you look at the total numbers there, you know, we're looking at about 1,500 a year average for pediatrics, so 0 to 17 for pediatric falls. And then if we go to just overall fall data, so those were severe falls, meaning they went to a trauma center. And then this is all age groups here, 0 to 17. And you can scroll down there and kind of see again that young age group is where we have the opportunity to maybe focus some education for parents. So what are some things to help with pediatric patients? What are the higher risk groups? So I wanted to make sure we weren't, certainly we recognize geriatric patients are a big component, but definitely there is a risk for especially the younger pediatrics. So I wanted to make sure we had representation from our pediatric perspective. So I don't know, Dr. Woolridge or Brianna, if you wanted to add anything in terms of pediatric specific metrics you would like to see us include or injury prevention ideas on this patient population. And then I'll come back to you, Melissa.
This is Dale Woolridge. No, I appreciate, I'm sorry, can you hear me okay?
Yes, we can. Thank you, Dr. Woolridge.
Yeah, I appreciate the inclusion of the minor population. The data looks complete. I thought the one I always struggle with is the inflicted injuries, where mechanism isn't always very clear or forthcoming. But I think the data is complete, and I appreciate the inclusion.
Thank you.
Hi, everyone. I'm also the EMS for Children Program Manager. So I agree with Dr. Woolridge that we are seeing that the data looks somewhat complete. I would also like to consider maybe having rib fractures in here as well, if that is a possibility for the future. Some initiatives that I think EMS for Children can take away from this is educating our families and having some more focus around safe play areas, as well as maybe some window guards for those high falls that are occurring in our lower patient base. So those are the two things that I'm taking away from this data set today.
Thank you. Melissa?
Yeah, I think, you know, we've been looking at pediatric falls as well as the geriatric falls. And it's, again, kind of circling back to that PSA campaign. This is a public health issue that doesn't discriminate based on age. We do have more older adults that fall than any other population. We know that, but no one's immune to it. And so I really firmly think that a massive public service announcement campaign to bring awareness to it, to try to change perspective, is really imperative on it. Just like I said, just like seatbelts back in the 80s, it was absolutely commonplace to nobody wore it, wasn't a big deal. We educated as injury prevention professionals and as trauma centers on why that seatbelt was important. And we talked about mechanisms of injury and crash dynamics. And then once people understood how it worked, then they started using it. I also think the financial incentive was huge in that as well. People don't want a $250 ticket.
Thank you.
Mm-hmm.
All right, I think we can go to the next slide. So one of the things we wanted to make sure we kind of brought forward was that we did have a request that came from staff that went to the education committee, and the education committee did publish a training specific to kind of fall injuries. So if you can click on this takes us to that. So this slide deck will go out after the meeting, and this will have the hyperlinks available for the education as well. So one of the things, a big thank you to our education committee and Dr. Rice, who chairs that, and just a lot of the trainings that have been put together that are available, that anyone can download these. You can make any adjustments, you can put this training on, and really gets into a lot of kind of fall data. We'll just kind of scroll through this relatively quickly, just so you guys get an idea of what is out there. You know, doing some of those assessments, you know, looking at things when you go on call. And this is really for any EMS provider. Obviously, if you're community paramedicine or MIHS, you can do more of this work and spend more time there. But really, when you recognize that an EMS crew that goes to a residence, there's often going to be many of them, and they do a lot of this. As people walk in, EMS providers are really good at taking in the whole scene and often recognizing what the risk is. And so kind of empowering people to say, hey, you know, take this opportunity to offer, can we take a minute or two and help address this specific thing? Looking at things that contribute to falls. Sorry, if you can scroll back up quickly, just things like polypharmacy, recognizing that many medications, also substance use is a big issue, even our geriatric patients. I always joke around that I'm an equal opportunity offender. I ask everyone, do you smoke, drink, or use drugs? Because I've had yeses from all age groups. And so I don't screen those questions. I tell patients, I ask everyone, but it really is amazing how much, especially some of our elderly patients do drink, and they start quite early in the morning, and what that contributes in terms of falls. So just recognizing that when you're on scene with these patients, there's a lot of other things that could be adding into why they could be falling. And then what are some other diseases that contribute to that? We recognize many of these patients have lots of other things that contribute. And so this is one of the big things that I like to really focus on is when you assess this patient, again, doing that exam, doing your SMR assessment, doing a quick range of motion on these patients, making sure that they can range all their joints and nothing's hurting them, have them ambulate a few steps in their own. And I think the point of if they're leaving the ED, this is a quality metric that many hospitals can do. When you have those weak, dizzy fall injury patients, road test them in the ED before they get discharged. Don't just move them from the stretcher to a wheelchair out to their car, but really have them walk to the bathroom, walk a little distance to the hall to make sure that they can safely do that. And so really looking at some of that piece. And then the fall and injury and anticoagulation, to your point, we're trying to educate EMS on, hey, if this patient fell and they're on blood thinner, they're at higher risk compared to another patient. So just identifying to them that even though right now they're fine and want to refuse, they do have a risk for delayed bleeding. And so identifying that as a risk factor, if they still want to refuse transport, just making sure that they understand that if they develop symptoms weeks later, this still could be related to that fall and anticoagulation use. And then we just get into some of the overall kind of related to refusals. We added some of that education. We can keep scrolling there. And then getting into some capacity. So this is kind of just a quick run through, but just wanted to make sure everyone was available. I think the committee did a really good job with this training. We wanted to keep it short and sweet, recognizing that for many EMS agencies, they're trying to balance all their training on shift. And so really the key thing with this is keeping something that was a little bit all encompassing, hitting and all of that can be done in probably 30 minutes. So that is available. We can go back to the slide deck. So, as Dr. Southworth mentioned and Monica mentioned as well, there are community care medicine and MIH programs out there in the state. We know that they are very effective. I would love to see some funding for this long term, because I think if there's funding available, there's many individuals that would like to continue these programs. Again, some challenges. So if we can see some traction with this, that would be, I think, a great help. And then wanted to see, trauma centers. I know there's a lot of injury prevention work that has to be done as a trauma center. How can we maybe loop in some of this fall prevention work? There's a lot of work that's done in some other injury prevention programs. Is this something that, to Melissa's point, we can maybe highlight at a little bit more of a statewide level? So wanted to see what people's thoughts were in other education and fall prevention programs.
I can speak to what I'm getting in my hospital.
All right, I will come to you in a second, Melissa.
So it kind of, I wholeheartedly agree with everything that Melissa said as far as changing the perception of falling and kind of educating our older adults that it is not a normal part of aging, but it's very common and there's things you can do to prevent a fall. So starting on a smaller scale, I've started doing education in my hospital to people that are age 60 and over, regardless of their trauma mechanism. So even if they're completely alert and oriented, functional 61-year-old that's out driving and gets in a car accident, I will go have a conversation with them about falls and fall risks and give them some collateral information about the importance of having a primary care doctor, kind of screening for these things, all the fall prevention stuff that we all know in the room. I just have a regular conversation with it, and I've kind of followed the SBIRT process. So the substance brief intervention and referral to treatment, I kind of have taken the same stance with falls and just like, hey, you may be at risk for this. Here are some resources. Here are some things I'd like you to do. In my hospital alone, I found that only 27% of my patients that are over the age of 60 are established with a primary care doctor, which we know is the first step to any sort of fall prevention intervention that you need to do. And I've also found that only like 5% of them are in full control of their health or are even aware of the risk of falling. But there is a small set that's like, yeah, I've got it. I have grab bars installed. I've already talked to my primary care doctor. I do a review of my medicine with the pharmacy. But 75% of them have no idea that this is an issue, and they're completely open to the conversation. So kind of, like I said, back to Melissa's original point, is just started spreading the like general awareness and education for my hospital and my population. And then I think to your earlier point, what I'm missing in my program is I don't have the capacity to capture all of the patients that are discharged home, which is where our huge opportunity is. And I think care management in all of our hospital systems would be a huge help to owning part of this process. But as we all know, they're stretched farther than probably anybody. But that's one of the little things that I'm doing so far, and just kind of collecting data. I don't know if it'll be helpful or not, but that's my program.
Thank you. And I think, you know, I do look at how you ask the question. Are you a fall risk? No one wants to say, yes, I'm a fall risk, versus when's the last time you fell? You can get very different answers to those questions. Not many people will identify themselves as a fall risk. And if you screen the question that way, you're going to get a no, versus asking when the last time you actually fell. So Melissa?
Yeah, they tend to lie on both accords, but yeah, how they ask the question is definitely important. But I mean, the statistics show that more than 50% don't tell anybody when they've fallen because it's embarrassing. I mean, I fell like down the stairs the other day in a parking garage, and I was like, before I even worried about if I was okay, I just worried about if anybody saw me. But I think it's just changing. A lot of it is changing perception, and how do we change public perception, especially with the family members. So stressing the importance of, you know, if they live at home with a family member and that they need that help to be taken care of, the importance of getting up and toilet, like helping them get to the toilet, toilet assistance. I think also one of our big problems, you know, I think everybody on the call can probably agree, you have different long-term care facilities that tend to be frequent callers with their patients. So if we can somehow work together to target those centers that have more calls than others and provide the staff with education, and maybe try to do some root cause analysis even. Why are they falling? Are they short-staffed? What is going in and looking at the facility, coming up with different training programs for those places. In regards to the Senate bill, they do have to, that was passed last year. They do have to have fall prevention education and literacy training per that ARS. So can we help support them? We do stuff with the AFPC. We have a training program that's free that they can take. But I think personally, in-person training is more effective. It creates a better partnership between the hospital and the assisted care facility. I think for many years, we've had a lot of contention between fire and assisted care facilities and the hospital. It's kind of like everybody's against each other in different silos instead of working together. So if the trauma centers can help support those assisted living facilities and build better business relationships, a more trusting rapport with them, maybe we would see some better patient care delivered. These are just my personal opinions, conversations I've had. I don't know that it's the answer, but I think it's due time to start trying something new.
Thank you. Sandy, I see your hand up.
Yes, I apologize. I joined late, so I'm not sure if anything I say has been covered. From the pre-hospital point of view, one of the things that I found when they're responding to these fall patients is the fact that they, especially for head strike, I'm now encouraging my crews to ask that question multiple times, multiple different ways, because of how the geriatric population perceives things. A head, did you strike your head, tends to mean did you actually hit your head yourself? So I've got them asking at least 3 different ways on head strikes or head bumps, or when you fell, did your head hit the ground? And that's kind of helping to find out, especially whether they're on blood thinners. The other thing is, we all know that when they get to the hospital, they're sometimes a completely different patient than what you started out with, because they change their stories. But that's one of the things. It's not necessarily fall prevention, but it kind of rolls into that, because when they do fall, a lot of times they do hit their head.
Thank you, Sandy. So one second, let me just bring the mic over to you.
The only thing I wanted to add is that I just think that the level ones really need to lean in to help out the level 3s and 4s for the fall prevention programs. When we're going on some of the state visits, you know, what are the level 3s and 4s doing? And just because of the limited resources, it's a flyer, you know, so those Tai Chi or those matter of balance classes and the coaches that we have, if we can expand our bench or expand the pool of coaches for any of those evidence-based programs, I think that would help the state as a whole.
And I think the trauma program managers work group that Kim runs, that's a really good avenue to kind of bring those different centers and different levels together to share resources. So Kim, I don't know if you're going to briefly touch on that.
One thing that I would kind of like to see, which is kind of building off of what Wendy's saying, is that since falls are such a big mechanism for these centers and injury prevention is part of the trauma designation, I would like to see us do almost something like what we did with Fish and Game, where we were able to develop kind of a canned sort of program that wouldn't be a huge lift for a trauma program manager in a rural area who's also functioning as a you know, the registrar and the infection control and stroke and everything
Multiple
else, that it would make that a little bit less burdensome for them to roll out in their community. Or even as Wendy kind of said, having maybe a team for the state that is dispatched to help centers or areas where you know, this is the program, we're going to teach you, like train the trainer type of thing. Just something like that I think would be really impactful, since this is something that is almost every trauma center we have. So
I'd be happy to share my collateral that goes out. I mean, it's taken directly from the CDC study program, which is not the best program evidence-based wise, but I think when you take the information that it has and you're delivering it in a different way to a different audience, my hope is that it's effective. So it's data that's already out there, that's already created for the patient population education. It's checklists, it's screening tools. It really can be implemented at any level hospital. The challenge is going to be, like right now, I own it at my hospital. So I've seen over 200 patients since I've started it individually. And of course, the people on the weekends and holidays and stuff don't get seen. So that's going to be the challenge anywhere, is like who owns the process. But if you have a robust case management team, care management team, nursing staff, even on the floors, could absolutely deliver this education. To your point, it's pretty canned up already, and I'm happy to share what I have.
Well, I think we are nearing the end of our time today. So I think we've got some great feedback from the group regarding kind of some additional elements. It looks like we'll work on a report kind of specific in addition to our fall dashboard, adding on some comorbid conditions. It looks like that's definitely an opportunity for us to look at that patient population, mortality rates and anticoagulation with a new page. And then definitely find a way to circulate out more some of the education that's out there for EMS. We have that curriculum ready, it's published, making sure people have that available to do some education for fall prevention. So I'll open it up to any other questions or comments for the group. I know Dr. Jones also wants to get your email address if you wanted to maybe email her kind of any other specifics you wanted for that report. And anyone else, my email is on the screen or was on the screen. You can email me and I can forward that to Voxel if you have any other specifics you would like to see kind of shared in that report.
And I'll add on and say big thank you, because listening to this dialogue is just amazing with everybody that's going virtually and then also in person. I don't like to talk a lot in these meetings because it's great to hear from the SMEs and hear all your recommendations and the great work you're doing. But as everybody's sharing what is happening in the state and some of the recommendations that we can glean from this group and STAB, TEPI, the trauma program managers that I know have met recently along with TRUG, if we can pull some of these recommendations coming out of this work group and incorporate them into the STAB annual report, I think that would be an excellent place to put some of these recommendations. So I just want to thank everyone for their input, and I hope that we can continue to get some momentum here to highlight the best practices and some health policy moving forward. This is really good stuff.
Thank you. Well, thank you everyone for bearing with us with the audio issues. I'm glad we were able to get it to work. So I hope you all have a good rest of your day and stay cool out there if you're inside your air conditioned area.
Stay in that
Thank you.
AC.